Okay, so let's go back to kind of TRT then. So we've kind of established what's going on.
When are you starting?
Yeah, we're going to talk about that. I'm actually doing my blood again next week, so we'll see how far my levels have continued to fall. So I was going to actually talk right about that, right? Which is, let's talk about quote unquote what's normal.
Mm-hmm.
So I've never found a compelling table for normal levels of free testosterone that are stratified by age. So you can find these data quite easily for total testosterone level.
Mm-hmm.
But I've only really seen data for broad chunks, prepubescent, pubescent, post-pubescent.
Yeah.
Here are the percentile ranks for free testosterone, whereas for total, I can show you by decade or something like that. I guess it's worth putting some context to this, right? So if a person's total testosterone is 800 nanograms per deciliter, most of that is bound, and sex hormone binding globulin and albumin probably do the lion's share of binding. And if a guy's got 2% of that as free or unbound, that would translate to 16 nanograms per deciliter of free testosterone. That's estimated, by the way. It's not calculated. It's very important people understand this. When you go to the lab and you get a test done, they're measuring testosterone. That's direct measurement. By the way, we should talk about ELISA versus LCMS. But they're estimating the free based on the measurement of the binding proteins. So that's introduction of potential error number one. So you don't really know how much free testosterone you have. The other thing is you don't know how many androgen receptors you have. So you really don't have any idea how much whatever amount of testosterone you have is saturating your androgen receptors or not. Are you playing below your weight or above your weight? So what do we know about the amount of total testosterone over time in a guy's life?
I know that after it peaks, you will have a steady, as opposed to women where you see like a plummet after menopause. For men, it's more gradual, and you can expect, I believe it's about 1% drop in total test per year, with an approximate 2 to 3% drop in free each year as well. So at the same time, you would have 1% total T drop, 2 to 3% free. And this occurs, well, it depends on age, lifestyle, but in general, like post age 30, 35, you can kind of expect a little bit of the decline to start. But that's not to say I haven't seen 70-year-olds with like 1,000 total T sometimes. So you can certainly retain high level production. I don't want anyone to think, oh, now that I'm 45, my levels have probably dropped 20+% at this point, I should probably get on TRT. Might not be the case. So in general, those are kind of general numbers of decline that you can expect based on literature, but I think it's reasonable to assume that a lot of people can retain good production as well. It's just a matter of, how well do you produce gonadotropins? How well do you respond to them at your testes? Because there is some level of function that declines with age too, even in response to the gonadotropins. And that's an expected outcome, unfortunately, but that's kind of where you get into the nuance of, is TRT justifiable for this person based on pituitary output, lifestyle, diet, nutrient intake, sleep hygiene, is there sleep apnea, etc., and then also actual testicular response, because there's an argument to be made if you have very good testicle response, like why would you ever be on exogenous TRT too? Because you could top out your natural signal even.
Is there an advantage to that? So I guess maybe before we get to that, let's talk about the rationale for TRT. So what do you think is the most compelling case for it? And how often are people, expanding that use case?
I think the most justified use for it is people who have primary hypogonadism. So that is when you have gonadotropins going to your testes, but you're just not responding to them. So LH and FSH you will see these as high in your blood work, but your total T is still bottomed out. Like that could be somebody who is, you should probably check, do you have a varicocele, do an ultrasound of your testes, see where things are at structurally, functionally, etc., before you make any rash decisions, because there could be something you're overlooking. And I do think a lot of people do overlook certain structural abnormalities that may otherwise be rectifiable. Kind of depends. But typically, testicular failure in response to adequate signaling would be like the obvious, more no-brainer, versus if you had low LH and FSH, maybe your testicles are fine. So why are you haphazardly getting on testosterone when maybe it's a lifestyle thing, you know?
And so, you know, typically when we see that pattern, the second pattern you've described, which is low testosterone, but in the setting of low LH and FSH, the most obvious things that usually show up there are poor sleep, and, you know, basically high glucocorticoids, which can also suppress the pituitary.
And you'd measure the glucocorticoids through like
Saliva,
a Dutch
or,
test?
well, you would, yeah, usually urine actually.
Okay.
We used to use saliva long ago, but yeah, so using a Dutch test.
Cool. Yeah.
Interestingly, those are not the easiest things to fix because people have to change behaviors, which is a lot harder than, you know, taking a medication. So let's just say we go down the path of we believe that TRT is the right thing to do, and we believe that it's primary hypogonadism. What do we know about the dose response of testosterone? And do we think that it makes sense to use fixed dosing and increased dosing, or target to certain levels? Because again, most of the studies, and we might talk about the Traverse trial, you know, they kind of just use fixed dosing, which is, at least for me, one of the criticisms of that approach, by the way, is you especially when you're using something topical and you have variable absorption. But what do we know about this?
Yeah, I think in general, like an accepted, if you're going to be treating with exogenous testosterone, an accepted entry-level dose that is on average safe and well tolerated and will get you to a reasonable total T that provides symptom relief for the majority of people is, like, I can't see a more logical start point than, for example, like 100 to 120 mgs a week or something of that nature, and just seeing what happens to the guy's total T, free T. This could also be, you know, variable based on, does he have a super high SHBG? You know, what should we be evaluating that? Because maybe he just has a low free T instead of his total is fine. In that case, you could have brutal symptoms, but your production is still good. It's just being bound up severely. And why is that the case? Do you have like severe liver issues or something? So after you flesh all that out and you determine the guy needs T, I would like imagine a reasonable starting place is typically like 80 to 120 a week, and then kind of, you know, go from there, see how you respond to that.
And any advantage to dosing it once weekly, taking that dose and dividing it by 2 and doing it twice a week, taking that dose and dividing it by 7 and doing it every day?
Yeah, and I don't necessarily know that, like, for example, when patients come to you, I'm sure they're looking for the highest level of optimization, hence why they're with you. So maybe it's more reasonable to expect them to pin more frequently. When I say pin, I mean inject. But there is a half-life associated, like, with the drug, depending on the ester chosen. Typically, testosterone Cypionate will be prescribed, at least in the US, that's the most prescribed one, which is a half-life of 10 days, if I recall off the top of my head. Depends on the person, of course, where it's injected, blah, blah, blah. But that half-life, you could, you know, extrapolate out from that. Okay, it's going to take 50 days to achieve steady state serum concentrations in the blood. And that's going to look on like a steroid plotter. You could check online and see this kind of like, you know, spiking until all of a sudden there is the same amount of dropping of the drug clearing out of your system. You're getting an equal amount of spike back up. Like there is no accumulation of drug burden after you've achieved steady state serum concentrations. So the advantage to injecting more frequently, and this is going to be determined largely by patient adherence more than anything, because some people simply refuse to inject even more than, I've seen some insane stuff where people will let themselves drop to literally hypogonadal territory and then remember, based on their dick not working, now I take my test. But in general, once a week is like bare minimum, I would say, but that's certainly not optimal. And I would say that 2 times a week, at least for somebody seeking good quality oversight, you know, preventative medicine, whatever, if they're coming to you or to somebody who believes in the same things you do, twice a week, I think, is kind of minimum for decent, steady, hormone concentrations.
Yeah, we've sort of arrived at the same conclusion that that's the sweet spot.
Yeah.
We do have a couple patients who do daily injections.
Yeah.
And interestingly, in these patients, we see much less for the same dose of testosterone. So you take, like 15 milligrams injected a day, which is actually very difficult to do. You have to be very thoughtful about what kind of needles you're using to actually get such a small volume in. But they will have much less FSH-LH suppression, which suggests to me that the higher the peak, the more the FSH-LH suppression. I don't know that there's anything physiologically relevant to that other than...
I think it's the studies when you look at trough level T levels, and when I say trough, I mean like the lowest point of hormone concentrations after an injection. Oftentimes these studies assessing dose response will look a week after your injection. So what you see in the literature isn't necessarily reflective of what's going to be in patients trying to optimize anyways. But what I see personally and in Merrick Health and through all my blood work that I've seen over the years, et cetera, the more frequent you get, there's a diminishing returns for sure, but you can lower the aromatization spike and 5-alpha reduction by going more frequent. So if you have a bolus administration of, I don't know, 150 milligrams once a week, you are literally spiking your T into supraphysiological territory acutely, and concurrently you are getting supraphysiologic conversion to estradiol, DHT. Yep. You also have a very, very aggressive spike in free androgenic signaling, which can crank your sympathetic nervous system up, impair your sleep quality. Like there's so many consequences people don't.
And you'll see more hematopoiesis.
Yeah.
So when I had Mo Kara on here, he was talking about Natesto, which is the nasal formulation, which has such a short half-life that it's actually a TID dosing schedule.
Wild.
So it's 7 milligrams of testosterone
I want to see
injected
somebody
intranasally
take
3
that
times a day
for more than a year and still tell me it's cool and fun to take. So if you end up doing that for TRT, you gotta.
I probably will not. But what his point was, two interesting points with Natesto. The first is they don't have the hematopoiesis. So you know, these are not people who are making too many red blood cells that you have to actually be careful of and have to go and get them therapeutically phlebotomized to take blood off them as their hematocrit gets over 50. Secondly, it's a FDA formulation that women can use.
Right. Because
if a guy is taking 7 milligrams in each nostril 3 times a day, clearly a woman could take 1 of those every other day. And by the way, it's sort of an on-demand libido tool for women in particular. So there are lots of interesting things around that. Also, they're doing a clinical study, and we're sort of observing what they're doing, where women are using intravaginal use, one application of that intravaginally before sex to enhance orgasmic function.
Nice.
So again, pretty. It's always desirable to have an FDA formulated product when you can kind of avoid the dark side of compounding. Is my view.
I think the best way to conceptualize for the listener too why this frequent protocol or getting a more stable level is even. Why does it result in a lower side effect burden too? It's the closest you can replicate natural function, the more you will replicate natural side effect profiles, which, should be nothing if you are physiologic. So with, Natesto, which is like in and out acutely, like so fast, you are not getting this huge spike to 1,500, 2,000 nanogram per deciliter total T. There is no situation ever in which your testes would just blast you once a week with a hammer of test and all of the associated metabolites and back end and consequences of that. You would have little pulsations over, a diurnal rhythm. And this is why you would test your blood as a natural in the morning when your testosterone is spiking, and it's going to ebb and flow over the day. Your test level in the morning could be 300 nanograms per deciliter higher than later in the day. Like, it fluctuates. So to expect that it's reasonable to jam yourself with an absurd amount of test in one go and then hang on that as it declines out of your body and then crank it to the stratosphere again once a week, it's just not representative of a physiologic state whatsoever. So the more you can replicate that diurnal rhythm through the synthetic administration route, the closer you're going to get to a lower side effect burden. Like, I've seen some guys that get gynecomastia from TRT dosages, go to ED, everyday dosing, and get off their AI. Like that's how significant.
Yeah. So just to translate that into English, you've seen guys who can take a weekly dose of testosterone, and in doing so, they make so much estrogen that they have to take an androgen inhibitor, an aromatase inhibitor to prevent them from getting breast tissue gynecomastia. Yeah. And if they take that same dose and divide it daily, they can come off their aromatase inhibitor altogether.
Yeah. And some people, it's problematic because they will give feedback to their doctor or just give a judgment to what hormone therapy was like for them based on what is maybe not the right dose, but also just not even close to an ideal dosing regimen and injection frequency.
When I got back into the practice of medicine and was learning about HRT, I couldn't find doctors who weren't prescribing anything different than every 2 weeks. That was the standard.
Have you seen the European Sustanon?
I mean, it's just, no, I have not. But so
dude,
the standard dose was 200 milligrams every 2 weeks.
Yeah. And
which immediately, I remember going through Llewellyn's pharmacology and looking at the pharmacokinetics and being like, this is an awful idea.
Yeah.
Any difference clinically between Cypionate and enanthate? Obviously, one of the advantages of enanthate is there's a commercial product called Zyosted for people who are squeamish about injecting that comes in a preloaded pen. Mm-hmm. So we have some patients who just don't like the idea of having to draw up a syringe, and they just kind of want something that's a little more turnkey. Mm-hmm. So Zyosted, which is a slightly different form of testosterone, but clinically, I sort of remember at one point there was some difference that might be age specific, but I don't recall now.
Yeah, the half-life. Enanthate is often thought to be a long ester, which it is relative to like propionate or phenylpropionate, but it's kind of like an in-between of cypionate and propionate. It's like a half-life of, could be as short as like 4.5 to 5 days, I believe, off the top of my head, whereas cypionate could be twice as long in some people. So it depends on your individual metabolism of the drug often. So, and also if you're pitting sub-Q or IM, like you could kind of like bleed out the effect more. So I would say if you're injecting frequently enough, it's essentially irrelevant. But with these auto-injector pens,
which is typically the auto-injector, the Zyosted protocol from the FDA is once weekly.
Oh, is it?
Which is actually, I mean, we still recommend people do it twice a week and just use a lower dose.
The difference of not using what you're supposed to take versus using it, like obviously frequency is of a lesser concern than you walking around with no test. So if it's the difference between a guy taking it versus not, okay, take your, once a week if that's what it's going to take. I don't know if is the preloaded dose can you modulate?
You can't meter it. That's what's so annoying about it.
Annoying with
it's
the
such
GLPs too.
It's such a racket because, and I always tell patients, I'm like, look, if you're completely cost insensitive, I guess fine, but otherwise, like getting, Cypionate in a jar is a fraction of the cost if you're just willing to be the guy that meters it out. But the enanthate, I think, only comes in 3 loaded doses of Zyosted. So you also have less wiggle room if you're not happy with the output.
I would assert with near certainty that you are not optimizing your hormone status if you are, when I say optimize, I mean just like dialing in the stability of it and the side effect profile and potentially quality of life as much as you could if you did a more frequent schedule, especially with enanthate. So once a week is a little bit.
Meaning you the more frequent you're giving it, the better.
Yeah. Like I think the diminished returns there's a significant drop off when you go from every other day to every day, but like 1 week to twice a week, like I'd say there's a pretty dramatic difference that's worthwhile to.
Yeah. Let's talk about the difference between sub-Q and IM. Again, I have always advised patients to do sub-Q for the belief that it has, as you point out, kind of you bleed out the effect a little bit longer. But I have to be honest, I don't think I've seen data to support that.
I have seen, and I think this is an extrapolation, but I believe it to be true, is when you look at sub-Q dosing, you'll notice the total T levels are higher. And then people take away from that, sub-Q is like you get more out of your test. But the reality is when they measure total test levels, it's often a week after your shot.
I see. So it just lasts longer.
So I think you are almost giving yourself a sustained release kind of through administering into the fat tissue rather than intramuscular, which is more readily absorbed, quicker blood flow, etc. Just like if you did like an IV administration, it would be like in your blood immediately. Not that you would ever do that, of course, but yeah, the difference in pharmacokinetic profile of like IV to IM to sub-Q, like you can change the same drug dramatically in onset of action through that.
So you think that sub-Q is probably a better administration. And so if you were...
I think once you get to every other day dosing, it's almost...
It doesn't almost matter.
Yeah, but I think especially for people who are doing... And again, it depends on the amount, because if you're doing once a week, is that going to be too much of a bolus like to sit in stomach fat? Depends on the person.
Yeah.
But, you know, I would say especially for infrequent, you'd be better, you know, sub-Q ideally if the volume of oil isn't significant enough that it's like creating lumps and stuff.